Welcome to lecture number 5 of our International Hands-on Laboratory Management Activity course. I am Polese, a senior embryologist from CFA Global Life, a fertility clinic in Naples, Italy. I will talk about PGTA, PGTM and PGTSR, practical aspects and new directions. First off, I want to quickly introduce the PGT. What is it? It's an acronym for Pre-Implantation Genetic Testing, and it's divided in 3 different tests: PGTA, PGTM, and PGTSR. The most commonly used is the PGTA. This test is used to detect embryos aneuploidies, which are one of the most common causes of failed implantation or early pregnancy loss. PGTM and PGTSR are genetic screening used in patients who are carrier or affected by specific genetic condition. Precisely, PGTM is used in case of monogenic disorder like cystic fibrosis or Duchenne muscular dystrophy. PGTSR is used in case of translocation, even in balance 1, since the incidence of unbalanced chromosomal translocation in these cases is extremely high. To perform a PGT, the embryologist will need to remove some cells from the embryo so they can be studied. Usually those cells will be inserted in a PCR tube, a procedure called tubing, and stored to be sent to a genetic laboratory, which will carry out the study. In the past, embryo biopsy was performed on day 3 embryos, extracting 1 or 2 blastomeres. Nowadays, the embryo biopsy is performed almost exclusively on blastocysts. This allows the embryologist to take more cells, between 5 and 10, without impairing the embryo development potential and improving the accuracy of the technique. This is a video of a real embryo biopsy performed in our center. The embryologist will take some cells from the trophectoderm portion of the blastocyst without even touching the inner cell mass to avoid any kind of damage. As you can see in the video, the process is very accurate and gentle to avoid to cause damage. Obviously, the video has been speeded up a bit, but even at normal pace, a biopsy of a single embryo usually takes less than 2 minutes. The cells will be then put inside a PCR tube using a stereo microscope and a stripper pipette. This is just an introduction, and we will go much deeper in the dynamic of the biopsy in the practical course. In the previous video, you saw the execution of the biopsy on hatching blastocysts. This is easily achievable through laser-assisted hatching that can be performed on day 3 or on the day of the biopsy. Both approaches have their own advantages. Day 3 laser-assisted hatching allows an early hatching of the blastocyst without the risk of touching any cells with laser shots. Moreover, the blastocyst will not need to push against the zona to expand, since as soon as the expansion process starts, the blastocyst will hatch through the hole we created. This will allow for an easier biopsy, because the cells will not stick to the zona, not applying pressure. As you can see on the video on the left side of the screen, if there are many extruded cells, they will be pushed out of the zona through the hole during blastocyst expansion. In our experience, this allows even lower quality blastocysts to expand, not having a physical encumbrance caused by extruded cells. In this case, the blastocyst quality is extremely low, but I have chosen this video to emphasize the concept. Another issue to consider is that extruded cells, even if few, during blastocyst expansion will stick to the trophectoderm, being almost indistinguishable from the actual trophectoderm cells. Those cells might have different genetic status from the actual blastocyst and might interfere with the analysis. The main issue of this approach is that, as you can see in the video on the right, hatching might start to or close to the inner cell mass, making embryo biopsy more complex. As I said earlier, we cannot touch inner cell mass cells. In this case, we might have to wait until the blastocyst herniates more, and this could be problematic in an extremely busy routine. Potentially, you could perform a second hatching, but this might be problematic for the blastocyst, since it would have two different points of etching and greatly impair implantation potential due a trapping event. If you choose to perform a second zone hole, I would suggest to connect the two. This could potentially cause the blastocyst to lose the zona completely, but it's not a big issue. On the contrary, laser-assisted etching on the day of biopsy allow us to perform the etching in the farther position possible from the inner cell mass, but we will incur on all the issues we listed earlier. There is no correct answer. It mostly depends on your routine and preferences. This is how a blastocyst etching from two different holes will look like. As you can see in the picture B and C, this may lead to a partial or total degeneration. There are two kinds of negative results we can have from a PGTA analysis: aneuploidy and mosaicism. The most common one is the former. PGTA is a test to assess the genetic health of embryos, analyzing the number of chromosomes. Humans have 23 couples of chromosomes, but with a surprisingly high incidence, human embryos, following a linear relation with age, have some alteration in chromosomal number. As explained in this slide, there are many negative effects related with aneuploidy, most of them not compatible with life, therefore causing a pregnancy loss or miscarriage. But some of them, like Down syndrome, Klinefelter, or Turner syndrome, allow a live birth, with either physical or intellectual disabilities. There are four types of aneuploidy: single chromosome loss, single chromosome gain, complex aneuploidies involving more than one chromosome, and segmental, involving only part of the chromosome. The second negative result we can get is the mosaic embryo diagnosis. This outcome is not nearly as dire as the previous one, since this embryo is able to lead to live birth. What is a mosaic embryo? A blastocyst can have two different cellular lines, one euploid and the other aneuploid. As shown in the figure, the rates and distribution of those cells can be extremely different, and so we might not even detect a mosaicism. When we perform a biopsy of a mosaic embryo, we might take only aneuploid cells, or only euploid cells, causing a false positive or false negative. Unfortunately, there is no way of knowing, and this is probably the greatest drawback of PGTA. How does a mosaic embryo originate? What I would like to point out regarding mosaicism is that contrary to aneuploid embryos that originate from aneuploid gamete, they originate from a mitotic error, subsequent fertilization, so mosaic embryo are originated from perfectly euploid gametes. The mitotic error can occur during any stage of development. The later it happens, lower will be the mosaicism rate. If the error happens in the early cleavage stage, the number of mosaic cells will be much higher. So, how should we treat mosaicism? Should we transfer mosaic embryos? Mosaic embryo can be transferred with a decent pregnancy rate. Live birth from mosaic embryo is around 45%, which is a really good chance in patients in advanced maternal age, where the rate of euploidy is around 20–25%. Mosaic embryo are a resource for the patient that should be not underestimated. Obviously, in these cases, even more, patient counseling is a focal point in the treatment. It's absolutely essential to explain the possible risk to the patient so they are able to make an informed decision. I want to make a quick digression to introduce a biopsy technique called flicking. There has been a current of thought that hypothesizes laser biopsy might alter the result of a PGT analysis, increasing the mosaicism rate. The latest studies seem to disprove this hypothesis, but no laser biopsy is still considered by some groups the safest option. As you can see from the video, you have to perfectly position the two needles on the same focal plane and push each against the other using the glass elastic force to abruptly cut the cells. It's an extremely useful technique and allows to perform a biopsy on a lower quality blastocyst that might be hard to cut with just a laser. It's a really useful tool in your embryologist toolbox. Before going further in the discussion, I want to briefly explain what happens to the cells recovered from the biopsy. When they reach the genetic lab, the cells will be lysed and the DNA will be extracted, and amplified through whole genome amplification. Basically, to simplify, the DNA will be amplified through a PCR reaction using a non-specific primer that will allow to amplify the whole DNA. This will produce a huge number of copies, starting from the few cells we had removed from the blastocyst. The amplified DNA will be then analyzed through RHGH or NGS. The first one used for PGTA was the RHGH, which is now obsolete. The technique consisted in a competitive hybridization on a chip. The sample DNA is marked with a fluorochrome, usually green, and mixed with a reference sample, marked with a red fluorochrome. The mixed sample is then hybridized on a chip. A software will then read the resulting fluorescence that will vary based on the DNA ratio, allowing to discriminate different kinds of aneuploidies. The NGS is the current gold standard for PGTA. It is almost completely managed by a platform. The DNA strand is amplified using a primer. Each nucleotide has its own specific marker, therefore the platform is able to read which nucleotide is being added during the amplification process, writing the sequence in real time. This is an extremely simplified explanation, but for the sake of understanding PGTA, it's not necessary to go more in depth. After this brief introduction to explain what is PGTA and its role in a laboratory routine, we will analyze the position of the main scientific societies on the topic. The subject is extremely controversial. Both ESHRE and SRM does not recommend PGTA for routine use. HFEA, Human Fertilization and Embryology Authority in UK, also branded PGT as a potentially dangerous add-on. So generally, PGTA is considered appropriate, although hardly recommended, only when some conditions are met. What came out from the study of those societies is that PGTA does not offer a higher pregnancy rate in all patient groups, but might be suitable in some subgroups. Let's check in detail. The SRM guidelines have not been updated in a while. The information in it are dated back to 2018, and some of the statistics are from day 3 embryos biopsy. Also, most of the data used was obtained through RHGH. However, currently, the analysis is performed by NGS, which greatly improved the result accuracy compared to RHGH. Those guidelines, as stated before, are from a study involving all group of patients, including those with a good prognosis. However, even with those limitations, patients aged between 38 and 41 years demonstrated improved live birth rates for cycle in a day 3 single blastomer biopsy. The reason behind PGTA controversial is to be ascribed to suboptimal evaluation criteria. Obviously, the same is not applicable to PGTM and PGTSR, because those tests are extremely useful in case of underlying genetic condition and are always advisable. ESHRE guidelines are in the add-on section of the site. Those are from 2020, so more recent than SRM1. Those guidelines gives indication which patients are eligible for PGTA. The most important criteria is advanced maternal age, which is the primary cause of embryo aneuploidy. Recurrent implantation failure and miscarriage are also parameters that might qualify patients for a PGTA. Finally, severe malfactor might also be an indication for a PGTA. However, from more recent studies, it appears to have higher influence only if the female age is above 38 years. This table shows that the rate of aneuploid sperm in patients in advanced paternal age, using 40 years as a cutoff, is increased more than threefolds. That is not negligible, but how is that reflected in embryo euploidy? There are many research aimed to identify the effect of advanced paternal age in IVF. According to these papers, the sperm age and quality has little to no impact on embryo euploidy if the oocytes are young enough. Probably this is due to the oocyte ability to repair sperm DNA damage. Paternal age, on the other hand, has many other effects, but this is not the topic of this lecture. This is an extract from ESHRE Good Practice on add-ons. Even if right now PGT is considered as a dangerous practice, it actually states that the parameters used to validate its usefulness are probably wrong. PGTA is a diagnostic tool. It cannot improve embryo viability or quality, so it cannot improve live birth per cycle. Probably other measures like miscarriage rate and time to pregnancy are surely more suitable parameters to evaluate this head-on. Some studies, however, did not find any difference even observing this measure, but all of them had some point of criticism. I can say that in my experience, as shown in the table on the right, maternal age is an extremely important factor in the risk of aneuploidy. According to this table, the aneuploidy rate rises exponentially with age, reaching an extremely high threshold. According to this, appears evident how, for a patient in advanced maternal age, would be convenient to opt for a PGTA cycle. More than once happened in our center that patient had one euploid blastocyst in a pool of 8, and it might even be the one worst ranked by morphology alone. In those cases with advanced maternal age and a good number of blastocysts, that is not so common even in older patients, I strongly suggest PGTA for a number of reasons. First of all, going through 2 or 3 failed embryo transfer really put a dent in patient confidence and trust in the clinic, and also takes a huge toll on their psyche. It's not uncommon for patients to give up before transferring all their blastocysts. Also, embryo transfer cycles are not free, so even from an economic standpoint, PGTA is advisable. I would also like to present this table from Cooper Genomics, showing both aneuploidy and mosaicism rates. What can we say about this? Not only the euploidy rate drop, but also the ratio between mosaicism and euploidy is slightly shifted toward mosaicism. As we said before, a mosaic embryo is generated by 2 euploid gametes, and mosaicism is caused by a mitotic error during embryogenesis. If the ratio euploid-mosaicism decreases with age, we can understand that older euploid gametes are more prone to mitotic error. So, how does age affect chromosomal segregation and consequently aneuploidy rates? This paper does an in-depth study from a molecular standpoint. The figure on the right side of the screen shows chromosome enveloped by a coil. This coil is a protein called coisin, which envelops the chromosome, keeping them close together. Apparently, coisin expression seems to decay with age. This causes a slight separation between the chromosome that is translated in an interkinetochore distance increase with maternal age, and therefore a premature separation of sister chromatids. Another possible cause of increased aneuploidy with age might be the telomerase shortening. Apparently, even if the oocyte is not dividing, the telomere shortens with age due to erosion and Ross effect, paired with a decreased activity of the enzyme telomerase. Apparently, telomere shortening increases the risk of non-disjunction, impairing spindle assembly. Both effect also correlates with what we saw in the precedent slide. Even if the oocyte is euploid, it has a higher risk of mitotic errors, and maybe the cause might be that the increased interkinetochore distance and telomere shortening might impair even subsequent mitotic division. Oocyte aging also affects ATP production due to mitochondrial dysfunction that is reflected in a less efficient spindle formation. As an interesting side note, aneuploidy follows a U-shaped curve, so not only patients in advanced maternal age have a high incidence of aneuploid embryos, but also teenagers, although the biological mechanism is not clear. There is a great number of studies on clinical pregnancy following a mosaic embryo transfer. All of them confirm a lower pregnancy rate than euploid blastocysts, but is still around 40%. The issue with the mosaic embryo is that, once again, patient counseling is fundamental. The patient should talk to a genetist, who will inform them of the risk of each specific mosaic embryo. Usually, it's advisable to transfer only embryos affected by a mosaicism not compatible with life, so the only possible risk is an early pregnancy loss. However, the other parameters should be taken into account, like the mosaicism rate. The final decision on the transfer should be taken by the patient after an in-depth counseling. Anyway, pregnancy rate is not the same in all mosaic embryos. This paper from 2020 ranks pregnancy rate based on the type of mosaicism. Apparently, the segmental mosaicism, even if of higher grade, has the better outcome. This table is extremely useful to decide the order in which is better to transfer mosaic embryos. So, why is the PGTA considered unsafe? We already found some of the issues of the technique. The first one is related to the risk of the procedure. As you saw in the video, you are actively manipulating embryo cells and cutting some of them using a laser. It's an extremely invasive and dangerous procedure for the embryo. The operator needs to be experienced and trained to perform a biopsy because it's extremely easy to damage the embryo beyond repair. As we said earlier, it cannot be 100% accurate, because we might fail to detect mosaicism falling into false positive or negative. It's expensive for the patient, making it not accessible for everyone. It also might damage the embryo. It's not possible to know if removing some cells might lower, even if extremely slightly, the implantation potential of the embryo. Another issue with PGTA is mostly psychological. Fail to perform an embryo transfer after going through the whole process might be traumatic for the patients. That is why, once again, counseling is the fulcrum of a PGTA cycle. Finally, the last point is the nightmare of each embryologist who perform an embryo biopsy: the infamous no results. Sometimes the cells samples might be damaged, insufficient, or of poor quality. Also, the embryologist might fail to correctly put the cells in the PCR tube, or the cells might stick to the pipette or to the inside of the tube. In that case, the DNA won't be amplified, and the analysis will fail. This will open two different paths. The patient might renounce to the analysis, sign a consent form, and transfer the embryo without a diagnosis, or they might decide to re-biopsy the blastocyst. This second option will force the blastocyst to go through a new thawing, biopsy, and refreezing cycle. How should we treat a no-result blastocyst? The correct consensus in literature is to re-biopsy the blastocyst. Unfortunately, the pregnancy rate of blastocysts which underwent a re-biopsy cycle is considerably lower than a blastocyst that has been biopsied once. Why is there such a difference? The question that arises from this study is: are we impairing blastocyst implantation potential doing a biopsy? Is each consecutive biopsy damaging the embryos more? Would the same euploid blastocyst have a better chance of implant if we did not manipulate it at all? Well, this paper might be the answer we are looking for. In this study, they compared biopsy cycles performed on fresh or frozen embryos. This second group, therefore, is going through a second thawing and freezing cycle. Those are not re-biopsy cycles. However, the reported pregnancy rate are superimposable to the result we just saw in the re-biopsy cycles. We cannot be sure that the double biopsy does not impair the blastocyst in any way, but for sure this study let us hypothesize that the bulk of the issue is the second thawing and freezing cycle. Is embryo biopsy the only way to evaluate the genetic health of an embryo? Since the introduction of conventional PGT, there has been a great effort to find a less invasive approach that could bypass most of the reserves against PGT. Non-invasive preimplantation genetic testing emerged from the discovery of embryonic DNA in spent embryo culture media. In this approach, the culture media is recovered and analyzed with NGS. However, non-invasive PGT accuracy is still inferior to conventional PGT. Moreover, many parameters can influence the results, namely culture condition, type of culture, timing of the samples, and so on. This requires a more versatile protocol. Also, the whole genome amplification method needs an improvement because currently components of the culture media can often cause a suboptimal amplification. On this regards, there are many studies to validate non-invasive PGT, and even if some of them find a really good correlation with conventional PGT, it's really rare to be completely superimposable. As we said, the main concern of PGT are both the invasivity and the false positive. Of the two, in my opinion, the biggest one is the false positive. Failing to detect an euploid blastocyst or a mosaic is a huge issue in a PGT cycle. especially if we consider that the patients that benefit the most from a PGT are those in advanced maternal age, that already have a low chance of getting an euploid blastocyst. There is also an issue on how to manage the report. Some provider will just sort the embryo according to the implantation potential, because they cannot give an euploid result confidentially enough. So how should we deal with the remaining embryos that are marked as unlikely to give pregnancy? Should we advise the patient to avoid transfer? It's a really complex issue, since you could theoretically suggest to the patient to perform a new ICSI cycle if the blastocysts obtained are considered bad prognosis, but that might lead to a huge number of euploid embryos being wasted. Right now, I would advise against introducing non-invasive PGT in a clinic, until the technique will be equivalent to conventional PGT. At that point, non-invasive PGT will completely replace PGT, being the best option. But until now, I think being reasonably sure in giving aneuploid results is more important than the lower invasivity of the technique, which is almost no concern to an experienced operator. This will be our last slide, and it's just a quick summary. In conclusion, PGTA is an extremely useful tool to reduce the time to pregnancy in some group of patients. However, not by any means increase the success rate for treatment. It's just a diagnostic tool. In the long run, will be probably replaced by non-invasive PGT, but we are still far from that point. It's still an extremely delicate procedure and need to be performed by a highly trained embryologist, but if performed correctly, most of the drawback of the technique can be overcome. Should not be proposed to all patients, but only to some subgroups, like proposed by the ESHRE. Need an extremely in-depth patient counseling before the technique and after to discuss the result. I also would like to remind the inclusion criteria we saw earlier, because it's a vitally important point. Advanced maternal age, recurrent implantation failure, recurrent miscarriage, and finally, severe malfactor. Although the last one is more controversial. Thank you for your time. I will be looking forward to your comments, and please do not hesitate to contact me should you have any unanswered questions.